Welcome to another episode of Let's Talk Small Data with T, where we are passionate about the power of small data in healthcare. I am your host, Tanazia Gonzalez, but you can call me T. Data has certainly changed the game in healthcare. Big data has blown the roof off, but small data, now that's the future. Small data allows us to dive deep into the key insights and take quick, customized action to achieve phenomenal results in performance and quality improvement. Let's explore this today. Thanks so much for joining us. If you have any questions for me or any of my guests, feel free to reach out to me at tgonzalez@eima-inc.com. Enjoy the show. Let's go. Welcome to the Let's Talk Small Data with T podcast, where we explore the power of small data in healthcare. Today, I'm so excited to introduce two individuals coming from the National Minority Health Association family to discuss how the organization is using small data to drive health equity and close the minority healthcare gap. Burgess Harrison, I'm so happy to have you with me today. He's currently serving as Executive Director for the National Minority Health Association. Burgess brings more than 25 years of home health, home care, electronic visit verification, and telehealth technology experience to the table. Burgess is an educator, he's an entrepreneur, and he has a passion for developing innovative and forward-thinking programs for nonprofit organizations. And I'm so very grateful to have him on the show. Welcome.
Glad to be here. Glad to be here, T. Thank you for the invite.
Thank you. Next, we have David Cole. Has recently been selected to serve as a board member for the National Minority Health Association. David Cole is an accomplished healthcare professional and business executive with 25 plus years of experience in building multiple successful products and companies. David is a certified chronic care professional and a California certified administrator for residential care facilities for the elderly. He is also a former Medicare administrator and a certified memory impairment specialist instructor. Out of breath. David Cole, thank you so much for joining me today.
Thanks for having me, T.
Thank you. I've been excited to really talk with you all about the organization and what you all are up to, especially what projects you're working on that will really use small data to drive quality improvement and closing the minority healthcare gap, something very near and dear to my heart. I really love the mission of the organization and what you all are working on. So, Burgess, if you wouldn't mind, or David Cole, somebody, let's dive in. Let's talk about the organization and pretty much what is it and what is the mission of the organization.
T, thank you again for having us. The mission of the Minority Health Association is very simple and complex at the same time. Simple in that we're all about healthcare equity and closing the health disparity gap, which you had talked about. And some people may be wondering, what is that? Is that an issue? Why is that important? And just a couple of quick stats. Black males have the shortest life expectancy, and I just saw something the other day that with COVID, African Americans had like a 1 year less life expectancy, and now that's increased to 2 years because of COVID. So in 1 year, it's gone up 100%. So wow. That's pretty, and we're all taking supplements and exercising in order to live longer, right? So we're kind of going backwards. Hispanics have the second highest level of Alzheimer's and dementia. Mm-hmm. That's pretty impactful. 50% of Hispanics also develop diabetes within their lifetime. Asian subpopulations and Pacific Islanders have 5 times the ratio of hepatitis B relative to Caucasians, and Native Americans have 2 times the level of diabetes. So those are just a tiny, tiny bit of the iceberg of the healthcare disparity that exists within America and probably around the world, but we're focusing here in the States. So we're here to first espouse and talk about and promote and create awareness for the health equity issue, because people really don't fully understand that it exists and what it means.
Hmm.
First thing is that people get health equity confused with health equality. Both are important, but they're two very different things.
Yes, I'm glad
And
you bring that up. Hmm.
and so I like to bring up the if you can paint an image in your mind of an apple tree. And on one side of the apple tree, the apples are 6 feet above the ground.
Hmm.
And on the other side of the apple tree, the apples are 10 feet above the ground. Well, in a health equality scenario, you'd give everybody 6 foot ladders, and okay, you'd get the 6 foot apples, but you wouldn't get the 10 foot apples.
I see.
If on the other side of the coin, if you gave everybody 10 foot ladders,
Hmm.
you're way overspending to be able to achieve similar results. And the healthcare system is, overtaxed and too expensive as it is. We're just not able to do that. So, in an ideal world, you'd want to give people that need 6 foot ladders 6 foot ladders, and people who need 10 foot ladders 10 foot ladders.
I
And
see.
then from there, you then can take the next step to beginning to get to healthcare equality. But you
So,
can't get to health equality until you have health equity. So that's
okay.
what we're talking about. So if I take a real world today example,
Hmm.
there's been a lot of talk about recently about pulse oximeter reading darker skin differently, which may or may not be an issue. But the point is that clinicians need to know that that could be a factor, and so
Interesting.
and some of them don't realize that. Now, when the pulse ox was invented, whatever 15, 20 years ago, no one was thinking that and planning for this to happen.
Hmm.
But at one of the areas in health equality or health equity is that when you do clinical trials, you want to be sure that you're testing all types of pharmaceuticals and equipment on all types and ranges of people
Hmm.
so that you would address these problems. And so that's why these things and these issues exist today. And we're here to bring this to light, make people more aware, and work toward eradicating the issue.
Interesting, like the pulse oximeter, it's called, right? That is a key tool in treating COVID, right? Patients with COVID. That's a cool a key tool that they use to understand where the patient is in terms of progress with their COVID, right? And
Exactly.
I had no idea that skin pigment could affect that, the reading.
Exactly. Now, I'm not trying to raise all kinds of alarms or bells. The point is that clinicians need to know that there could be a difference
Right.
when darker skin is red, and they need to know what that might mean. So they need to
Right.
find out and have that information available to them.
Have
And
that as
that's
part of
really
their plan. Right.
exactly that's really the issue. So in we need to look at in the medical world, and David can probably speak to this better, that but everything works on standard of care.
Mm-hmm.
And so if you're trying to achieve health equity, we're going to have to go and look at the standard of care, which is when somebody has a particular diagnosis, this is what you do, and you take these steps, use these, particular protocols to address it. That's the standard of care. If you go outside of that, then, a clinician could be liable, if there's a problem.
Right.
So standard of care needs to be looked at across the board,
Mm-hmm.
and you have to start from the time that something was either designed, invented, manufactured, in order to see that, okay, did XYZ, whatever that is, take into account all types of, whether it's men or women, all types of, races, and any other factors that are necessary to be sure that it's effective. So let's go to COVID. You take the vaccine. We're going to be launching a vaccine confidence campaign very shortly. And
Oh,
one of the reasons is that there's a hesitancy about taking vaccines in the public just in general. I forget the exact number, but let's say it's probably like 30 some odd percent. In minority communities, it's over 40%. So that means you have people who are fearful for various reasons for
mhm.
taking the vaccines. And then you have politicians that add to the mix. Last week we heard a mayor say that the Johnson and Johnson vaccine was inferior. Basically, I'm not quoting him, but that's basically what he was saying. He canceled an order for it because he wanted his citizens to have the best. And what that does is it only adds to that, when in reality, all of the vaccines, regardless of the three that are out,
Hmm.
all of them prove 100% effective at eliminating death. They're all effective at keeping you from having a severe case of COVID, which is, keeping you out of the hospital.
Right.
And so that's what's really important. And that's what people need to know. And any of the three, if they're offered to you, you should take them and take it as
Right.
soon as possible. But when you have, again, politicians saying things that are really inaccurate, it doesn't help. So we have a campaign that we're going to be launching very shortly in the next
Hmm.
couple of weeks to help promote uh, and uh, and reduce the fear of taking the vaccine, in particular in minority communities, but it relates to anybody. So
Nice.
look for that coming soon.
Beautiful. I look forward to hearing more about that. Um, so at National Minority Health, I've heard you talk about Operation Healthy You. What is that program? What is that about? And how does that tie into the PAM? I guess we also have to define the PAM and what that is and what it stands for.
Well, first of all, yeah, PAM stands for. It's not the can of spray that you use on your pants thing from sticking. PAM stands for Patient Activation Measure.
Yes.
It's been out for, I'm going to say, approximately like 20 years. It's
Okay.
probably one of the most highly researched, processes and protocols out there. I believe it's up to 600 peer-reviewed studies that have proven this to be accurate. And what PAM is a set of questions. Now it's 10 questions you take, which will identify whether you're a level one, two, three, or four. And the key word in the name of PAM is activation.
Hmm.
You're trying to understand in a person how activated they are relative to their healthcare. If you're a four, you're highly activated, meaning, I'll use this as an example. If a physician tells you that you have uh, cancer or whatever it may be and says, do these 10 things and it will provide you with the best or optimal outcome possible for your height, your weight, your living condition, whatever it is,
Hmm.
the level four person is probably going to do that. They may even do 11 things.
Hmm.
And so the doctor can have probably a detailed discussion with him or her about what's going on. And that person's going to be very activated in their uh, uh, particular healthcare situation. Go the other way to a level one, somebody who is not as activated, which has nothing to do with their intelligence. It just has to do with whether they feel that they have a responsibility for their healthcare and the outcomes that
Hmm.
they can get. And a level one, there's I guess I'll call it a detachment from that. They would look to the healthcare professional to do all the work. For example, if you had to take 3 or 4 pills a day, an activated person is going to, you tell them what they're going to need to do, and they'll probably just take care and do it. A
Hmm.
level one, you might need to call them every day at 10 o'clock in the morning to say you need to take your 3 or 4 pills today.
Okay.
Then you have the two levels in between. But I just wanted to show and discuss what the extremes are. So the goal in healthcare should be to get people to be level as close to level four as possible, as activated as possible, and take ownership of their healthcare. Because by doing so, you're going to get the best and most optimal outcomes for that person for their particular situation, which reduces hospital stays,
Hmm.
reduces readmissions, and reduces healthcare costs, and gets that person the best outcome for whatever situation they're in.
Right.
And so that's what, in a high level, and I'm probably butchered it, but that's a high level about PAM. And you stop and think, gee, why isn't everybody using this? And
Hmm.
that's our question. And that's one of the things that we're going to be working on. So PAM is an underlying philosophy, an approach, and a tool
Okay.
that the National Minority Health Association has adopted and will be utilizing within our Operation Healthy You program, which we're in the process of rolling out and working with home health and home care because they have hands on the patient
Mhm.
And in fact, I would say to you that in a home care world, they're kind of using PAM and they don't even realize it. When you have a home health aide that goes into a home, they know that Mary Jones will do something or won't do something, and they adjust how they operate with that particular patient. So they're kind of doing this because they see these folks, every day, twice a week, once a week, so they have an ongoing relationship
Right.
with that particular patient, and they get to know the particular circumstances, and they adjust. So they're kind of doing some of the, some of the things relative
Right.
to
Right.
PAM,
Right.
and not even really realizing it. There's no name on it. So now, if you went and told them, hey, this particular patient is an activated patient, and here's are some of the pathways, the protocols, the way that you should be working with them, we can take and structure that relationship that they
Mhm.
have and make it more effective. Now, some of the issues, in terms of chronic diseases that somebody may have, they're never going to, they're not going to be cured, but you
Right.
certainly can, you take dementia, but you certainly can improve somebody's, life along the way. And if
Right.
you take dementia, half of the issue or the battle is the caregiver because it's a 24/7 uh, situation,
Yeah.
and caregivers get burnt out.
Oh, yes.
So if you have a dementia patient that's a level one, the
Mhm.
lower end of the spectrum, and you have a caregiver that's a level one, well, that's going to tell you a little about that relationship. If you have, one of them is a level four, there are different things that you may want to do
Mhm.
relative to those interactions. Dave, anything you want to add to that? Because Dave's our dementia guy.
No, I think you did a great job describing it all, Burgess. Uh, yeah, PAM is a wonderful tool for identifying how to best approach
Mhm.
individuals.
Mhm.
And what I like about the PAM tool is that it's not a population health tool that makes, large scale assessments of large populations. It's a one-on-one individual tool because each person is different and
Right.
each person needs to have their care catered to what their specific needs are. And so that's what PAM does. And then with our Operation Healthy You, it's going to be a series of programs. The first is dementia, and it's basically ready to go to market right now. And the dementia program is intended to have two different approaches. One is directly for the care provider of a person with dementia. That's the first audience for this.
Mhm.
And secondarily is what Burgess was saying, the home care community. They need to be able to know how to care for these patients, and it's different than how they care for patients who suffer from other diseases outside of dementia.
Mhm.
So the dementia program, we think will be a very, very helpful tool, and we're working hard through a variety of community organizations, churches, local groups to get this into the hands of the people who need it.
Beautiful.
And
Yeah.
T, some of the what from a minority National Minority Health Association,
Mhm.
the dementia program can be used with anybody, whether you're a minority or not. One of the things that's come to light with COVID, and a lot of things have come to light with COVID, if you take, for example, Philadelphia, which is, I think it's like 44% Black population. In January, there are articles that were in the Philadelphia Inquirer that said that over 40% of those that were eligible for the vaccine
Mhm.
received it, but only 19% of those who were eligible were Black. And so you're thinking,
Mhm.
okay, how is that possible? That didn't make sense. But
Mhm.
as you started digging into some of the numbers, people could see that if you went to nursing homes and care facilities, there are smaller Black populations in those locations, which says that doesn't mean that there's not an impact of dementia within minority communities. It just says that they're not in care facilities, which means that somebody at home is taking care of them, and
Right.
so
Right.
they need a program. And so I bring that up to say that some of our programs will have tweaking and custom tailoring for minority communities, but
Mhm.
some of them will just be programs that they just never had access to, which is a part of health equity in terms of people not having access to the things and the care that they need in order to have an optimal outcome for their situation. You
No.
take
Burgess brings up a really good point there. There's actually 8 areas, T, that we look at
Mm-hmm.
for to identify the problems that we need to address. One is lack of affordable, high quality food. We run into communities like the Navajo Reservation where
Mm-hmm.
there's an epidemic of diabetes, and we find out that, well, their only food source is the local 7-Eleven.
Mm-hmm.
And and they don't sell natural foods and they don't sell organic foods. They
Food deserts.
have a lot of
Mhm.
sugary stuff and things like that, and as a result, that's the result of that's where it leads. So affordable, high quality food is not something that's impossible to get to them. It's just not profitable enough for
Right.
a big chain to for Kroger to put a big store there. But there are ways, and Burgess has been brainstorming on many of the ways to get these foods into the hands of people who need them, whether it's
Right.
community centers bringing in large quantities to community centers who can then distribute out to the community. Things like that are the kinds of things we're working on. Access to adequate healthcare resources. If you live in certain parts of town, you can't get to the places that offer services.
Mm-hmm.
Sure, it's great that the facilities say everybody's welcome, come in, but if you can't get there, you can't get there. So you
Right.
don't get the service. Lack of proper healthcare education. People don't really know what it takes to keep them healthy because they've never learned it.
Right.
And in a lot of schools, they don't have the resources to teach it.
Healthcare literacy.
Lack of access to proper pharmacy services.
Mm-hmm.
Walgreens and CVS aren't moving into the poorest neighborhoods. They just aren't doing it.
Yeah.
It makes it much more difficult. Um, that finding the time, the money, the financial wherewithal to get needed services. Dealing with people who understand your language and your cultural differences. That is probably one of the key uh, barriers to healthcare equity. And
Mm-hmm.
uh, a lack of literacy to understand the meaning of healthcare advice.
Mm-hmm.
We see it all the time. Patients
Mm-hmm.
leave the hospital with 13 pages of discharge instructions in fine print, and they say, "Well, I can't even read that with my glasses."
Garbage. Mm-hmm.
Garbage, into the garbage, exactly. And then the lack of quality care in underserved communities. That's they are in fact underserved. There needs to be more service, more focus, and as Burgess says, they may need a longer ladder than people who are outside of that community setting.
Right.
And we need to get them that ladder just to bring them up to a standard of care.
Right. Right.
Forget equality and equity, just to bring them up to a basic standard of
A
care.
level playing field. Yeah.
That's less
So,
than level, just a livable playing field.
right. Thank you, David.
so
I appreciate that. I just want to say that as you guys were talking about the 8 areas that you're focusing on or that contribute to the gap and
Yep.
the healthcare gap. I'm having a young lady on soon to talk about the farmers market that she built for her community, which addressed this issue of the food deserts. So
Fantastic.
she has the farmers coming in and it's really to improve the access to healthy, clean foods. She's also part of some work for the shelter, helping folks in that community combat these issues that just became heightened during the pandemic, but they've always been there.
Well, when you look at the
So,
waste in food in this country, it's
yeah,
phenomenal how much food is thrown out, wasted that should be properly distributed.
right, right. I always think it's doesn't make any sense for people to be starving or have nothing to eat in this country. It makes no sense.
No sense at
Um,
all.
So this podcast, we focus on the use of small data. Um, what I love about this project, Burgess, I love that you speak in numbers. Percentage of this, percentage of that. It's great. I love it. And obviously, it's this digging down to the small data that allows us to see, oh, it's this population that's having this issue, and this is where they are, and this is where they live. Um, for this project that you all are initiating, Operation Healthy You, how will you all be using data for this project? And I know the PAM, since I have experience with this in the
Right.
past, creates a lot of data,
A lot
excess
of
data,
data,
a lot of
yes.
data
So
that
that's
you could
so
comb through and really put it to work for you.
so
So
you hit
what?
upon it, that PAM is and why it's the underpinning of what we're doing, because we are going to be able to get good data
Right.
that will be actionable to help
Hmm.
get better outcomes. So it's
Right.
not data for data's sake. So
No, of course.
that's the
Yeah.
other benefit.
It,
Hmm.
You
it's it's also interesting that you use the term small data, because for us what that means is we're pulling data at the local level for the
Hmm.
individual. So
Individual.
we can not only model areas and communities, but we can drive it down and model the individual. And
Yes.
that's where I think data modeling at the small data model really is that's our sweet spot.
Yes. And that's what gets me
so
really excited about working with small data, just
right.
really diving in, taking the big data, highlights and diving in and seeing exactly where you can hit to move, take some action, first of all, and move things forward, and improve quality of lives.
Absolutely.
So,
So one of the things, right now, without PAM,
mhm,
decisions get made based on certain, social determinants of health and zip codes. So, we think by getting real information from
mhm,
real people, anonymous, you can make some better decisions. We'll be able to take certain pieces of information and go to whether it's the CVS's or Walgreens or supermarkets or whatever of the world, or the food delivery services, and be
mhm,
able to provide information that could be helpful to them in their planning in order to be able to begin to better serve and reach these communities. But we know that everything is economics. People just aren't going to or can't do things because of costs, or it's not economically feasible.
mhm.
So using PAM, we believe will begin to, and over time, begin to give us that data in a granular format to be able to help people from a planning perspective, and
Mhm.
to be able to deliver services in a more equitable manner. Because you don't want to give 10-foot ladders to everybody. Because we just can't afford to do
Right.
that. Plus, there may be, and I'm making this up, I know, but I know there's a whole thing about ladder. People go to school to learn how to use, those industrial ladders. I mean, there's a whole big thing about safety. And so I
Right.
don't know where there's a cutoff, but I'm sure between different sizes of ladders, to use that analogy, you need to have, different sets of training. Your insurance may be higher. There may be more accidents that take place as you get taller. All those other kinds of things. Again, another reason why you just don't want to, use the same, approach or tool
Mhm.
with everybody. The old adage, a carpet, if you only have a hammer, the solution to every problem is a nail. And
Right.
not always that's not it's not true.
Right. Right.
And that's often, what we do. If you go to a surgeon and ask them for help, chances are the answer is going to be, I need to cut you open.
You need a surgery. Yeah.
Yeah, right, exactly. So we need to, get out of that cycle and get to, more preventative measures, look
Hmm.
more holistically. And by the way, it's important, people who are healthy and saying, what does health equity have to do with me? Why should I care? And why should I care if there's health equity in minority communities? Well, it's important. One, we all pay for the healthcare system. So those public hospitals that take everybody that doesn't have insurance,
Hmm.
somebody's got to pay for that. Taxpayers pay for that. So if you
Yeah.
can keep people out of the hospital, whatever hospital it is,
Right.
that's a good thing. People working, the less days that people are out ill or sick, that's a good thing.
Right.
We saw again COVID, how bad it was. It showed us a lot of things. You take the meat packing plants that just got hit, like
Hmm.
in waves of people. Hopefully people are now thinking of strategies and plans in order to keep people healthy and keep people safe, and,
Right.
and not just with a pandemic. I would submit to you that we may not have known about COVID, 2 years ago,
Hmm.
but businesses need to have better, and I'm on a little soapbox here because I did some work in this. people need your businesses need to be better at disaster planning, and disasters could be anything. And how are you going to keep people safe? How are you going to
Mhm.
continue to work with your customers? How are you going to have supply chains that are robust and resilient and self-healing? It's all of those things, and we need to do the same from a healthcare perspective, and that needs to be for everybody. We can't, just because we don't see a particular community every day doesn't mean it doesn't impact us. So those,
Mhm.
migrant workers who got ill with COVID that couldn't, pick the lettuce, everybody saw that across the country because we couldn't get, you know,
Right.
or, in appropriate quantities for a period of
They
time.
call it the butterfly effect, right? It's a ripple effect.
That's
You
Right.
right.
know, something happening over here that you think has nothing to do with you eventually will make its way because we're all connected.
Yes, but getting back to your, the small data. So with
Mhm.
PAM, one of the
Mhm.
things that we're going to want to look at is, how can we, not just how can we, but are people moving from a level one to level two, and what
Right.
might be those things that are driving that?
Right.
Because if we could find and understand those things that are driving people's improvement from one level to another, well, hey, we want to replicate that, in more places, and then we want to figure out, okay, once we know what those drivers are,
Mhm.
then we want to figure out, okay, how can we reproduce those cost effectively and in a
Right.
timely manner. So those are some of the things that we want to see and find from a small data perspective utilizing PAM. And so we want to work with health plans because uh, that's where most people get their insurance.
Mhm.
And
What about those who are undocumented? Are you
well,
working with?
that's going to be a challenge. We're going to have to work with community organizations that already have relationships and access into undocumented communities,
Okay.
and which is another area. People may say, "Gee, that's not my concern," but okay, but undocumented people are here. Doesn't matter what your politics are; they're here. They have an impact. It's, and I don't want to get into a political discussion,
Yeah.
but I, whatever your belief is, I would hope that you'd want to have an undocumented person have a driver's license and gone through some kind of program to know that they are safe on the road.
Right.
Okay, again, regardless of what you may, your politics about it, we all want to be safe. Well, think
Right.
about that relative to healthcare. We want to be sure that everybody who's in this country is healthy and safe and not
Right.
spreading anything. They're following, the best information from the CDC in terms of what to do, what not to do,
Right.
and on and on. So we want to work with those groups that are already in those communities,
Okay.
and work at providing them tools that can help them, and PAM being one of them, that can help them for understand what's going on. It's look at it like intelligence in order to them develop and implement really good strategies to provide the best healthcare policy possible in the right way.
Right. Are you all using like a special, first of all, the PAM survey, is that like publicly available out there? And what system are you all using to collect the data from the participants?
Great question. We are in the process, as we speak, of rolling out in home health and home care. There
Mhm.
are SaaS, software as a service,
Okay.
companies that provide various types of back end, as we call them, software systems
Hmm.
for agencies and home health, home care providers
Hmm.
so that they can do their human resources, they can do their payroll, they can do their billing,
Hmm.
clinical documentation, and so on. So we are in the process of rolling out the PAM questions so that they can integrate them into their systems.
Okay.
So, and there's not a cost to them. And when I say not a cost to them, they'll have to do some programming, but there's not a charge for them to implement these systems. The cost comes into play when they are, in quotes, flipped a switch and turned on. You're collecting a survey and there's licensing
Right.
and things like that that comes into play. But actually getting them out there so that they're available for use, we're reaching out and working with, for example, Tim Rowan, who has the Tim Rowan Home Care Tech Report.
Okay.
We're working with him to roll this out to the home health, home care IT vendors.
Okay. So, so in terms of the administrators of the PAM survey. It'll be the home health staff uh, administering the surveys. I know I'm getting into the technical
Yes,
aspect of the
in
program. I
terms
was
of,
just curious.
well, those that have hands on the patient in terms of actually getting the surveys filled out, yes, they would be working with the patient to
Okay. Okay.
get them to.
There's actually a variety of ways to get the PAM survey completed.
Okay.
Once we get the 10 questions and we identify a potential participant,
Hmm.
then we can begin to plan a strategy for reaching out to the participant. And
Okay.
typically that's when we would be looking at what are the home care resources that are available
Okay.
in the areas where they live, and how close can we get them to resources, and all of that begins at that process, at that step.
I see. So the PAM tool is actually being used as an eligibility
It,
tool as
not as
well.
an eligibility, because everybody's eligible. If you need
I
help,
mean, for this particular project.
it's not eligibility for the project either. It's
Oh,
simply
okay.
categorizing
I
where
see.
the people are when they come in, so
Got
that
it.
we know how to address them, how to talk to them, and how
Hmm.
to deal with them to get the best outcome.
Where they
Nice.
are from an
Okay.
activation perspective.
Yes.
Right. It doesn't do us any good to go to the Navajo reservation and lecture them on you need to eat organic fruit. They would just look at us like we're crazy. Great, bring us
Right, right.
organic fruit. But, so you have to not only identify the community and modify the program for the needs
Yeah,
of that community, but you
totally.
also need to take into account within that community
Hmm.
who is level 1, 2, 3, and 4, because level ones are going to need a whole lot more hand holding than level fours.
Yes. Or high touch.
Right.
Yes.
Um,
And as we said to you, we want to work with health plans because
okay.
that's where most people get their insurance and
Right.
their healthcare coverage. Because they would be the ones that, in a lot of ways, get outside of the patient and getting better outcomes. The health plans are the ones that get the big benefit for it because the reality is they can save money, and
Right.
that's a big part of what it's about, and we can't shy away from talking about that. Our healthcare
Right.
system, the way it is today, and
Yeah.
not going to get into again any political discussions, but it's healthcare is it's a big business, and when you talk about big businesses, that's big money. So if
Totally.
large health organizations are able to save hundreds of thousands or millions of dollars because they're able to be more efficient
Hmm.
and be able to provide the right services to the right people at the right time in the right manner in the way that that person can address it and they can keep
Right.
them healthier, they save money.
Totally. I hear you. And I've been in healthcare for about 20 years, and the whole time I've been working with data with the purpose two reasons: to help improve quality and reduce costs. And really looking at the small data and diving in and trying to develop the interventions and the tools that we need to actually implement the interventions to do those two things: improve quality and reduce costs in multiple programs. And we are now getting short on time. We're getting close to close, and I'm really enjoying this conversation. I really want to hear more about Operation Healthy You. I love it. I would love to connect you with some folks I'm working with, especially the young lady who just put together the farmers market. She's doing some great things. There are other people who are implementing projects that are along the lines of what you all are doing. I would love to connect you with them as well. And perhaps we can have a subsequent show where we talk about, okay, how is Operation Healthy You doing? What has the impact been? Looking at the data and the numbers, and have we moved the needle? So with that, any final closing comments or anything you'd like to say about the National Minority Health Association or the program, or this closing the minority healthcare gap and the whole talk of equity before we
Well,
close?
I'd like to start by saying thank you for having us on,
Thank you.
and clearly Burgess is more articulate than I on this, so I will pass the mic, and Burgess,
I
on
don't know
you.
about all that, but yeah, I would like to thank you as well. We you heard us talk a lot about PAM we feel we're evangelists, and that this needs to be used everywhere and anywhere. But in particular, if we can get health plans to utilize this within minority communities as a tool to help them plan and provide the right services to the right people at the right time in the way that they can hear it and understand it, it's a win-win-win proposition for everybody. And so we're going to be on a mission this year and out years to be able to talk to every health plan possible that will listen to us. So that's like the big message. And then look for our vaccine awareness campaign that's coming out. I think people will enjoy it. It'll be different, and it'll be enjoyable, and it will convey information. Start the process of conveying information that's kind of complex, but not really hard. And when you unpack it, I think people will get it. And I think people are only getting, I won't say inaccurate information. They're just not getting the whole story.
Right.
And
Right.
you got to get to the end of the day. At the end of the day, people need to remember whatever shot you're offered, take it. So
Take it. It's better than nothing.
we're stealing this we're borrowing this, if you will, from Lin-Manuel Miranda. It's like, don't throw away your shot.
Totally. Thank you so much. I appreciate that. I look forward to hearing more about that. And please do let me know if there's anything that I can do to help you all further your mission and help you out with your various projects that you're working on. Once again, thank you, Burgess Harrison and David Cole, for joining. And thank you, listeners, for tuning in. To subscribe to the podcast, you can find us on Spotify, iHeartRadio, and TuneIn. And look up Let's Talk Small Data with T, no apostrophe. You can also visit eima-inc.com and click on Let's Talk Small Data to learn more about the podcast. And this brings us to the end of the program. I want to say have a wonderful evening. And remember, unleash the power of your small data. It's your most valuable asset. See you next time. This episode is brought to you by Effective Information Management Assistance, specializing in healthcare small data and offering expertise that goes beyond technology. Visit www.eima-inc.com to learn more about Emma and the podcast, Let's Talk Small Data.